Yeah, thanks very much, Alberto. I'm speaking in the place, I assume, of someone with a little bit more experience than me. Uh, just working on getting control of the screen. There we go. So here's what I changed it to. Rather than my 30-year experience, because I don't have 30 years, I'll call it the 40 years of arthroplasty experience by all of my accumulated colleagues in past, the efforts of generations of orthopedic surgeons. So I remember standing and talking to some of my senior colleagues, Joe Schatzker included, about I&D and washout and component retention 25 years ago. And he presented me the literature going back another 20 years from that. So it's been a long time. If we look at this award paper, The Fate of Two-Stage Reimplantation After Failed Irrigation, Guo mentioned it, 30% failure rate. So I do think that essentially leaving an infection untreated in a soft tissue envelope does make it more difficult to eradicate. If we look at the failed two-stage, so if you failed that first two-stage and you go through it again, this is Mayo Clinic data, your successful reimplantation really does drop dramatically. So failing that first DARE or washout, failing a two-stage, which is a higher risk, then leads to an even worse outcome in these patients. And why do they fail? It's a biofilm. So, you know, we're talking about 6 weeks of continuous drainage, and we know the basic science. Alberto touched on some of it, but this biofilm is fairly established within 6 to 12 hours, at least within 48 hours. So I would argue, hope you like this slide, guys. I would argue that this is a type A host. He's 47 years old. He has a tremendous amount to lose, and it is not normal for him to have a draining wound. So think of it backwards, not just looking at the outcomes in type A host, that's fine. But why on earth does a type A host have 6 weeks of drainage from his hip? I think he's in real trouble here. So I would argue that we did not achieve a timely diagnosis here. I would suggest that it's very important we identify the organism, and in doing so and appropriately treating it, two-stage reconstruction is the way to go. The consensus agrees. I will bring up something Guo said very quickly, which is 4 weeks. We're at 6 weeks in this case, so we're even further out, 50% longer than they would suggest for the DARE. In preparation for surgery, one thing that may have happened in this gentleman on antibiotics, I think we really want to avoid treating people with antibiotics and putting our head in the sand, as I mentioned earlier. Optimize the nutrition and anticipate any soft tissue problems, which I hope wouldn't exist in this young gentleman. You're going to get good tissue cultures. Don't take swabs, get good cultures. It is really important, as Mike Cross mentioned, to accurately diagnose what the bacteria is. So in the first stage, I'm fairly aggressive. I have a low likelihood of using an ETO. I do an extensive debridement. I get lots of cultures. I use high dose antibiotics. I learned that in my fellowship 15 years ago. Sterile mineral oil, I tend to use this prosthesis. I have no conflict. It's a Prostalac prosthesis. I use the longest stem. It gives me the longest surface area for antibiotic secretion and elution into the bone and soft tissue. Here it is, again, a long ETO. I fix it with 16 or 18 gauge cables. Almost always use the longest head size. That's a stability issue, despite the fact that it's snap fit in there. It's a very small cup, so when you tend to place it more superomedially, so you get more leg length out of a long ball. Little tip I learned doing it a lot. And collars of cement to reduce the risk of subsidence. Outcomes have been fairly good. I think one issue has been instability. In the second stage, you could consider a dual mobility. The consensus suggests a mobile when able. Dislocation can be left alone, interestingly, as long as it's not compromising soft tissue. I like Mike Cross's point. I have a liberal use of wound vacs. That might have prevented the issue that got us to this 6-week point. I don't tend to use a drain, as was shown in that photo. This allows you to do culture-directed antibiotics, monitor the inflammatory markers, and really allow you to reimplant in the best host you can achieve. We give them an antibiotic holiday as suggested by this paper. Time Timing of reimplantation, a little bit up for debate, but I tend to wait a few weeks off antibiotics. Second stage reimplantation, this gives me a second chance to make sure that the soft tissues are healthy and appropriate for reconstruction. Two-stage exchange long-term outcomes, if you look at them, 15% for Mayo Clinic septic failure, 12% dislocation rate. So we should target those two areas for improving our outcomes. I do agree on the long-term antibiotic prophylaxis. If you have an oral and tolerated target, I think this is a strong point for any mechanism you use. And I think this is a really concerning paper about a one-stage revision, because what we found is that there could be a real concern when you have an ongoing or persistent infection. So we still have a bit of work to do. This is a devastating complication. The only thing you can do is make it worse. So I suggest a two-stage. Thanks very much.